Lee is 58 years old. He recently had a below-knee amputation. This was due to a severe infection related to his diabetes. He is now beginning his journey in rehabilitation. He can stand with assistance but feels unsteady. His primary goal is clear and deeply personal. He wants to walk independently again using a prosthesis. However, he is afraid of falling. He also experiences persistent pain in his residual limb, which we often call the stump. The rehabilitation team has fitted him with a temporary prosthesis. The central question for us, as physical therapists, is this: what is the best, most effective plan to help Mr. Lee achieve his goals safely and confidently? This scenario is common in our clinics. We meet patients like Mr. Lee every day. Hope, fear, uncertainty. Our role is to provide a clear, structured path forward. This essay will outline such a plan, designed specifically for physical therapists. Our first encounter with a patient like Mr. Lee sets the tone for the entire rehabilitation process. Before any physical tests, we must start with a conversation. Take the time to sit down and listen. Ask about his pain. Ask about his fears. Ask about his personal goals. Understanding his psychological state is as important as assessing his physical condition. Check the condition of the residual limb. Look closely at the incision line for signs of redness. Look for excessive swelling. Look for drainage. Gently feel the skin to check temperature and texture. Note the shape of the stump. Note the condition of the scar. This initial observation gives us crucial information about healing. Next, we move to a thorough physical examination. We need to establish a baseline. Assess range of motion in the hip and knee. Assess both the amputated and the sound limb. Test the strength of key muscle groups: hip extensors, hip abductors, knee extensors, core muscles. These muscles are the engine for prosthetic gait. Assess balance, first seated, then, if safe, standing with support. If he can ambulate with a walker without a prosthesis, observe his gait pattern. This reveals motor strategies and compensations. Evaluate sensation and ask about phantom limb phenomena. Ask Mr. Lee to describe sensations in the missing part: phantom pain or non-painful phantom sensation. That distinction guides interventions like mirror therapy. Before Mr. Lee can even think about walking with a prosthesis, we must prepare his body and his mind. This pre-prosthetic phase is where the most critical groundwork is laid. Our primary focus is on protecting the residual limb and managing its volume. We will teach him how to use a shrinker sock. We will teach him how to use an elastic wrap. This compression is vital for reducing edema and shaping the stump into a form suitable for a prosthetic socket. We must provide clear instructions on how to apply the wrap evenly to avoid pressure points or restricting circulation. We also need to emphasize repositioning frequently. We must prevent joint contractures, especially at the hip. Pain management is another cornerstone of this phase. We coordinate with the medical team to ensure prescribed medications are effective. For phantom limb pain, we introduce non-pharmacological techniques. Mirror therapy is a powerful tool. Use a mirror to create a visual illusion of the missing limb. This can help reorganize the brain's sensory map and reduce pain signals. We also teach relaxation techniques, such as deep diaphragmatic breathing. These methods give the patient tools to manage discomfort and improve control and well-being. Ensure Mr. Lee is safe moving in his immediate environment. This starts with bed mobility. We teach him to roll from side to side and to move from lying down to sitting at the edge of the bed safely. From there, we progress to transfers. Stand pivot transfer to a wheelchair and to a bedside commode are key skills. We always use a gait belt for safety. Therapist stands on his weaker side to provide support. If he cannot bear weight yet, we teach slide board use. Finally, targeted strengthening and conditioning begins. These simple exercises prepare him for prosthetic demands. We focus on hip and core muscles, gluteal sets, bridges, side-lying hip abduction. For below-knee amputees, knee extension strength is important. Quad sets, straight leg raises. Begin gentle, then gradually increase intensity. Early strengthening prevents muscle atrophy and builds power for later prosthetic control. Section 4. The temporary prosthesis: donning, doffing, and initial balance. The arrival of the temporary prosthesis marks a significant milestone for the patient. It is a tangible symbol of progress. However, it also introduces a new set of skills that must be learned meticulously. Our first job is to teach Mr. Lee how to care for his prosthesis and his skin. This starts with daily skin inspection. We instruct him to use a mirror to check all surfaces of his residual limb, every morning, every evening, and especially after wearing the prosthesis. He must look for any signs of redness, blisters, and skin breakdown. We also teach him proper hygiene, how to clean his stump, and how to clean his prosthetic liner. Learning to put on, don, the prosthesis correctly is a fundamental skill. And learning to take off, doff, it is equally important. We must break down the process into simple, repeatable steps. Apply prosthetic socks. Apply the liner. Ensure no wrinkles. Slide the limb into the socket. And secure the suspension. Pin lock, sleeve, or suction. We practice this repeatedly until he feels confident doing it on his own. Patience is key. We must allow him the time to master this process without rushing. Once the prosthesis is on, our focus shifts immediately to balance and weight bearing. This begins in the safety of the parallel bars. We instruct Mr. Lee to stand with both hands on the bars for support. The initial goal is to get comfortable with weight on the prosthetic side. We encourage gentle shifts from the sound leg to the prosthetic leg, using cues like feel the pressure through the bottom of your new foot. This builds trust in the device and reintegrates it into his internal map. From static standing, we progress to dynamic balance, reaching forward, to the side, and across his body. We can add very gentle perturbations to stimulate automatic balance reactions. The goal of this stage is not to walk, but to build a stable foundation. Without it, walking will be inefficient and unsafe. Section 5. Learning to walk again. A staged approach to gait training. With a solid foundation of balance established, we can begin gait training. The first phase takes place entirely within the parallel bars. Our initial goal is proper weight acceptance on the prosthetic limb, then secure single limb stance. We cue Mr. Lee to step forward with the sound leg, fully transferring weight onto the prosthesis, and to achieve equal step lengths. Using a mirror provides valuable visual feedback. Once he shows control and confidence in the bars, we introduce a standard walker or a cane, depending on his balance and strength, and transition to an open level surface. Priorities remain: weight acceptance, equal step length, and a smooth, controlled rhythm. We start with short distances. We provide constant verbal cues to correct common deviations. Leaning too far to one side, taking a short, quick step with the sound limb. Safety is paramount, so we always guard closely with a gait belt. As endurance and skill improve, we increase complexity. Longer distances, turning both directions, stepping over small objects, transitioning from tile to carpet, and dual task training such as carrying a light object or conversing while walking. The final stage of basic gait training involves stairs and ramps. We teach a step-to pattern, up with the good, down with the bad, always using the handrail and close guarding. On ramps, shorter steps with a slight forward lean uphill, and controlled descent by riding the prosthetic knee and hip downhill. Mastery here is essential for community independence. Section 6. Collaboration and troubleshooting. Working with the prosthetist. A successful rehabilitation outcome is a collaborative team effort. The relationship between the physical therapist and the prosthetist is central. We must maintain open and frequent communication. As the therapist, you see the patient moving for extended periods and know their functional limitations and gait deviations. The prosthetist is expert on the device, its fit, alignment, and components. Together, you form a powerful diagnostic and problem-solving team. Act as a skilled observer of prosthetic fit. After wear, remove the prosthesis and inspect skin. Look for redness that does not fade within 15 to 20 minutes, likely high-pressure zones. Document and communicate locations with photos via secure messaging. This feedback enables precise adjustments to relieve pressure. Troubleshoot systematically. Tripping. Weak hip flexor, a patient issue? or insufficient foot clearance, a device issue, uneven step length, fear and lack of weight shift, a training issue, or prosthesis too long, short, an alignment issue. Form a hypothesis, review with the prosthetist, and adjust as needed. Collaborate on patient education. Manage sock ply for daily limb volume changes, and help patients translate vague complaints into specific feedback. For example, I feel pressure on the end of my bone when I take a step. This optimization makes therapy more effective. Section 7. Putting it all together. Progressing skills and ensuring long-term success. As Mr. Lee's basic walking becomes consistent, progress training for real life. Move beyond simple, straight-line walking. Build true functional independence. Create a simple progression plan focused on real-world tasks, getting in and out of a car, navigating a crowded hallway, and walking while carrying a bag of groceries. Each session should build on the last. Systematically increase challenge. Always prioritize safety and proper form. Track progress objectively. Timed up and go. 2-minute walk test, 6-minute walk test, and patient-reported measures like the prosthetic evaluation questionnaire. Show progress to the patient, to insurance providers, and to the healthcare team. A data-driven approach validates interventions and guides future treatment. Watch for common mistakes that derail progress, rushing and advancing too quickly, resulting in fatigue and compensations, failing to listen to pain or skin irritation, working in isolation instead of with the team. Avoiding pitfalls requires discipline, patience, and commitment to interdisciplinary care. Use a simple checklist each session. Help Mr. Lee not just walk, but walk well and with confidence. His case began with fear and pain. It can end with a fulfilling life. Careful assessment and foundational training. Collaborative troubleshooting. Functional progression into real life. That provides the roadmap. Call to action. Stop guessing Gait. Adopt a systematic, patient-centered, team-based approach to guide patients toward better, safer, more durable outcomes.